Today I have 10:31, so I apologize for being late. First off, I want to thank the members for being present, and I hope yesterday was an eye-opener. For those of you that were not here yesterday, I hope you are able to go online and pull the visuals up and go through the slideshows that were presented. And with that, anyone got any comments they want to start with? If not, Dr. Harris, are you ready?
Yes, sir.
Come on. Thank you for being here, Dr. Harris. It's good to see you.
Thank you. Good morning. Thank you for having me. It's good to see you all this morning. We appreciate the opportunity to kind of explain as much as we know about fiscal 27 and everything that's happened kind of in the meantime. What I really wanted to do was just sort of describe for you what we've seen kind of this year in the past few months to get a sense of, sort of where we normally would expect ourselves to be, and then I'll sort of explain some of the changes that we've seen so far. And frankly, there's a lot of uncertainty, as you know, going into the next 5 weeks or so, waiting to see what a new continuing resolution looks like coming out of Congress. So I'll just say that to start with. I do want to spend a little time talking about CHIP. CHIP obviously is very important to us and to the state. We're really grateful that the legislature has always seen fit to support that. It's a wonderful program, and it represents the biggest single item in our budget, of course. And so we're going to show you kind of what our best guess is about what CHIP is going to look like, and talk about what funding needs we may have about that. Our job is just to promote the health and wellness of people in our state. We want Alabamians to be safe and healthy. We have a great department of men and women who work really hard trying to do that. We could not do it without your support, and we're very appreciative of the support that you give us in our mission to help take care of people. So just to remind you sort of a big picture, we are largely funded by federal sources. About 2/3 of our funds come from federal sources. This is actually fiscal 24. I'll show you 25 in a second, but this is, these are actual sources from fiscal 24. About 2/3 of our funding comes from federal sources. Another 20% comes from clinical reimbursement that we get largely by billing for Medicaid recipients, billing Medicaid for services to their recipients. So about 2/3 are typically grants that we get, and then another 20% comes from Medicaid. So we are largely funded with federal money. We get, in a typical year, somewhere around 9 to 10 to 11% of our funding from general fund, and then with a little bit from the ETF. With the general fund money, obviously, CHIP is the biggest part of that. We also have a fairly substantial part of our general fund appropriation that goes to pay a Medicaid match as well. So a lot of that money is used to draw down additional money. So when you consider the Medicaid revenue we have, we're kind of 85 to 88% federal dollars that run into our agency. That was 24. This is fiscal 25, which is not quite final because we've still got a few more weeks, but the pattern is still the same. So about 2/3 federal funding and about 20% Medicaid reimbursement.
Can I ask you a question right
Yes,
there? Remind me, we had this conversation on the unwinding and the roll-off of people off of Medicaid. That prompted us to increase the coverage on CHIPs. How much was that increase?
It went to from 58 to
about 89.
89. It went from about 58 million to about 89 million.
Pretty substantial.
Yes, sir.
Okay.
That's right. It is.
And does that number seem to be, and you can follow back up later, but does that seem to be sustained? It's pretty consistent numbers.
So I am going to show you that.
Okay.
So what we're anticipating is a little bit of an increase just based on the normal increase we see every year in enrollment, and then just also cost. Its costs go up a little bit. So there's the request the estimate that we have that we may end up requesting for fiscal 27, you'll see is an increase on that number too. It's about 15 million increase is what it will show, and that's there's some slides on that I'll get to in a few minutes.
Okay, thank you.
Yes, sir. All right. So I just want to run through again a few things that happened to sort of set the stage for where we are. After we had a new administration operating HHS, we saw some pretty significant changes that happened quickly. The first thing that happened really was in March when we had several grants from fiscal 25 that were clawed back. And this, as you know, this wasn't just an Alabama issue, but happened all over the country. Really, one of our biggest single federal grants is called ELC, for short, Epidemiology and Laboratory Capacity. That's a grant that all state health departments have gotten for over 30 years. Those grants got a lot bigger during COVID, as you might imagine. That was the vehicle that the feds used to push a lot of money out for laboratory work and infectious disease related work. And so we learned in March that we had about 160 million left in this year's funding that got clawed back. And these were these are funds that the feds had already approved our work plans. We had contracts out with nonprofits and hospitals, and as well as our own laboratory to spend that money, and we had to stop work on those. And that money was never released to us. So that was the biggest single thing that we faced back in March. We've not got access to that money again. We had some smaller grants as well that I listed there for you, but all in all, we had around $175 million or so of money that we thought we had on a Monday that we didn't have access to on a Tuesday. And that's has a lot to do with what I'm going to continue to show you there, I guess. The next thing that happened is that we learned about this reorganization at HHS to create this Administration for a Healthy America, and we certainly support the administration's goals in trying to do that. We don't have a lot of clarity on how we're going to get funded, if we're going to get funded, or how we're going to get funded. There are a number of individual federal agencies and offices that fund public health that all got lumped together into the plans, at least for this new AHA, Administration for a Healthy America. So we assume maybe that we're still going to have access to the funding for those programs, but we just don't know yet because the plans for that have not come out. HRSA and OASH are probably the biggest parts of HHS now that we get funding from that are going to be lumped into the new AHA. Of course, the biggest single funder for state health departments everywhere is CDC, and CDC lost a number of basically any non-infectious disease program mostly got moved from CDC into this new Administration for Healthy America. So it may be okay, but we just don't know at this time because it's not clear the structure of that. We don't have contacts in this office or with any of these programs who know really how the funding is going to work. So we're waiting to find out about that. You can see these main areas of focus that they're working on listed there. These are all things that we have funding from various agencies for, but at the moment we just aren't quite sure how that's going to continue.
So before we go, if I might, Dr. Harris, so from what I'm hearing, since March, you and the current existing fiscal year, you're not getting an estimated $175 million from federal funds that you'd anticipated and had been working with. So that's just stopped, right?
Yes, sir, that's stopped.
And the programs have stopped.
And the programs have stopped.
And what you're telling us here is that there's more challenges in the upcoming year as to, with the reorganization and such, with what may or may not be coming to you.
Yes, sir. That's exactly right.
Do you have a dollar figure on that?
I do have some things, but they're going to be wild guesses in a sense. I know the funding that we get for the current programs that we have, and I didn't have a slide, but I'll be happy to show it to you.
No, that just
all of you. But it's, the question is, are these programs still going to be here after September 30th or not? And some of that has to do with what the proposed appropriations bill is from the White House that I'll show you, which is proposing eliminating some of that. As you all know, right now, Congress is debating that, and the Senate has done a good bit of markup on that appropriations bill. The House has yet to do that, but they've only got till September 30th to get a continuing resolution, or we have a shutdown. So what we understand is that the House subcommittee that controls HHS funding, that it's Health, Education, Labor, and Pension Subcommittee, is doing markup on September 4th, is what I've been told. So next week, towards the end of next week. And then the full committee is supposed to do markup the week after that. So that'll leave about 3 weeks in the month for them to take what they've got and compare it with what the Senate's got. And then we'll have a clearer picture. I think we'll have a good picture in October, hopefully. But we just don't know for sure right now. Did that answer your question okay?
Kinda. My concern is we're in the current fiscal year, which is what, 25, isn't it?
Yes.
Yeah. And that budget is, and according to your chart, is 863.5 million. And then we've got 26 starting. We've already budgeted for that year. That's starting on October 1st. And I'm assuming that the federal amounts, if you had to put a pie chart there, you don't have a figure for that.
We do not.
But I'm assuming also that it's going to be somewhere south of 700 million or less than what we had in 24.
We would expect that. Again, we're the fiscal 26, which starts October, which you all addressed with us in the last session. The whole federal aspect of that, we're not going to know anything until October.
So your stretch point is not necessarily trying to get together on what your budget that we're going to be dealing with in January, which would be 27, but getting through 26.
Yes, sir, absolutely.
Is that what the message you're giving us?
You said that more clearly than I did, but yes, sir, that's what I was trying to say.
I'm sorry I said that for you. I'm sorry, go ahead.
Okay, thank you. So the AHA, as you know, was enacted then through H.R. 1, the big beautiful bill, and that also included the Rural Health Transformation Grant. I think you may have heard a little bit about that yesterday, but this is put into statute as a $50 billion grant over 5 years. It's available to the 50 states. It's not available to D.C. or the territories. But it's available to 50 states. Alabama has should receive at least $100 million a year for 5 years for this, with the opportunity to receive up to another $100 million a year, so maximum of $200 million per year over 5 years. We had our first call with the people in my position. Had our first call with CMS on Friday. I think they've talked to governors a little bit earlier last week about the program. We still don't know what it looks like. The grant application itself is supposed to be out in mid-September, and then has to be turned around by the 1st of November, and the awards have to be made by the end of the year. So it's an enormous amount of money. Again, we're not sure what the application is going to look like, but these are the areas that they have announced that they're looking to address. They have to do with healthcare delivery systems and access to services in rural areas, and they want our applications to represent that. I say our applications. The application is going to be run from the governor's office. The governor, will make that determination about how that application gets done. We've, contributed our information to that. So have a lot of other agencies. So have a lot of others outside of state government as well.
Dr. Hasper, Representative Lee has a question.
Have they given you any indication of what the definition of rural is going to be?
No, sir, they have not. We asked the question last Friday on our call, and the answer to most of those questions was, you'll get the instruction soon when the application comes out.
Okay, thank you.
Representative Lee, I can tell you, I don't know the words. I know when I drive through it, and I know you guys in the urban areas have difficulty understanding that.
I do too, but I think we have about 5 different definitions here floating around.
We do.
Curious.
We do. Yes, sir. Good point.
And there are different programs have different definitions. It's not always intuitive. So there are a lot of people, obviously, who are interested in this, and certainly our rural hospitals, our rural providers, but also agencies that are doing work in these rural areas. All of them certainly have some interest and would seem to have some claim to be recipients of this. We just don't know yet what that'll be, but certainly that'll be.
And Dr. Harris, the biggest problem we have in rural areas is keeping our hospitals open, and we don't have an answer on that. One thing that we failed to do yesterday in Medicaid was ask about changing the pay system so that rural hospitals got paid the same amount. I'll have to do that privately, I guess, but until we change the Medicaid system so that we get equal pay in those areas, we're not going to be able to keep a margin there. That's part of the problem. Again, it's a federal issue in that regard.
Yes, sir. I agree completely. Absolutely.
And I think, if I might say, Mr. Chairman, I think EMS as well. We've got to have that conversation. I know some of the rural EMS is tied to our rural hospitals, but some are not. So it'll be interesting to see how they define that going forward from CMS.
Absolutely. I'll say when we gave thoughts to the governor's office about ways to address some of this, and EMS was definitely part of that. We certainly do think that that's part of the rural healthcare system. I mean, absolutely is. So just a few words about the White House proposed budget. There's some question marks on there because some of these things that were addressed there have already, on the Senate side at least, have already been changed a little bit, and we're still waiting to see what happens on the House side. So again, I have numbers for these. If you want to know what funding is right now on these, I can certainly supply that for you. But essentially, I would say these are programs that are a big part of what we do in public health, and we just don't know, right now on September the 27th, we don't know what we're going to have funded October 1st. It's not clear. The hospital preparedness program that we work with hospitals, rural and other hospitals, and EMA and first responders and communities to be prepared for disasters. That one was initially cut. We think it's going to be restored, but it was initially cut. So we're not sure about that. The public health emergency preparedness program that we operate in public health, this is how we serve our emergency support function 8 for natural disasters. We staff medical needs shelters. We, do lots of things in time of disaster. That funding has been proposed to be cut. We have a tabletop exercise going on right this minute at the RSA Activity Center with UAB and a bunch of veterinarians and public health folks about bird flu, and those are the kind of things that we can pay for with public health emergency preparedness funding that right now has been proposed to be eliminated. Basic disease things like STDs and TB are going to be moved to the new AHA, and we just don't have information yet about the funding. It's been proposed that the funding on that is going to be about a third less than what we currently get, but we don't know that until we see how this comes out, what Congress finally does with that. So if I'm confusing you, I would say that's kind of how I feel. We don't have a lot of clarity right this minute on what we're going to have funding for soon. So, but happy to answer questions as best I can. So this is what this has had us thinking about.
Dr. Harris, yes.
I'm sorry, I didn't see vaccination. Did I miss it on your list? It's in. So am I missing that, or are you going to talk about that at any point?
I'll say something in a second, Representative Hall, but essentially vaccination funding is level or maybe increased a little bit according to what they have announced. So we have not seen proposed cuts to vaccination programs yet.
All right, thank you.
So what this has had us thinking is we really have spent a lot of time trying to figure out what Alabama Department of Public Health is mandated to do. We have, obviously statutory obligations. We have a lot of things that we think are good ideas to do, a lot of the services, particularly in our county health departments, that we think are important, that we want to sustain. but we've tried to identify these core functions that, federal law or Alabama state law says we shall do, and this is a good overview of that, and you can sort of see over there radiation control, vital stats, the Vaccines for Children program, the federal program. We're required as a state to have that program in our agency, although we're not required to be given vaccines ourselves. Our cancer registry, our child death review, our prescription drug monitoring program. Most of these are programs that are run from our central office here primarily, and most all of these on this list, well, all these on this list are required things that we will need to find a way to continue doing somehow in order to stay compliant with our responsibilities. We have a list of things, and it's a very short list, but we have a list of things that are kind of discretionary, and I would say, in short, they're most of our clinical services. The birth control, family planning services we provide, immunizations that we give for kids, back to school shots, STD testing, the sort of core public health functions that we do. We aren't required to do. We don't intend to get out of that business. We believe everybody ought to have access in their own county to these kind of services. But I just wanted to make the point that we don't know for sure about continued funding for those things. And maybe we'll know a little more soon. So this is kind of our best stab at fiscal 27. The real change, if you just go to the next to last line, that's the significant number on that chart. The additional CHIP match that we anticipate is about $15 million over last year to this year. So that I'll show you. I can come back to that, but I can show you. 26 is budgeted at about 85, and then 27 we have estimated will be about 100 million. Our agency, our CHIP folks have worked for a long time with an actuarial firm at Mercer. They, basically just have the formula that looks at what our utilization was last year and what our expected enrollment is, what inflation is, and what, healthcare costs are doing, all those sort of things. And that's how we come up with this number. It's typically pretty accurate. It was completely inaccurate during the public health emergency when we had all these kids who went to MCHIP and never came back because they weren't able to be released from Medicaid. So we had a hard time predicting what the future was going to be during the public health emergency. But generally speaking, this is a pretty accurate estimate, we think. And so this is sort of our best guess for fiscal 27. About 15 million in additional match for CHIP. And just a couple of other items about CHIP. I don't think I have to tell you all what a great program it is. CHIP is really how a government health care program ought to work. These are for working Alabama families. These are, this is not a giveaway program. These are people that have cost sharing and they have copays and deductibles. And they get low-income people access to the Blue Cross Provider Network, which is the broadest one here in our state. And
Dr. Harris, what's CHIP stand for? What's that acronym?
Which one?
What's CHIP stand for?
CHIP stands for Children's Health Insurance Program, and so that was created in the mid-90s.
And CHIP's first word in that is children, correct?
Yes, sir.
Age group of child? Are we talking about 21, 18?
Under 19.
Under 19.
Is it, or 19 and under? Under 19.
Under 19.
Yes, sir.
So CHIPS are dealing with those children from basically prior birth through 19 years old, correct?
Yes, correct.
I like where you're going with this. Go ahead.
Because it's only been a recent endeavor where the general fund actually took in and brought in the funds for CHIPS money in regard to this. We may have to revert back to a previous methodology in order to fund the matter that's going here. And I'm saying that not to you necessarily, but to my colleagues in the legislature as where we are. The general fund in the past has taken over several things in the last number of years. And now, just to reiterate, CHIPS is we're 58 million. Now we're up to 89 million. Now we're looking at 100 million. Okay. We also, for those of you that don't recall, we were taking money and frankly out of the road and bridge money, and we were sending it to the general fund to help Aaliyah. And we were also taking money out of the road and bridge fund and sending it to the courts. And both of those were totaling over $100 million a year. Now we have, on the general fund, we have stopped that. All the money, the gas money and such, goes to road and bridge. But we have, on the general fund, taken that over as $100 million, and now we're looking at, so we're beginning to talk about some real money. We may have to look at some cost sharing here or methodologies so that we get back. Now, I'm not talking about taking money out of road and bridges, but I am looking at taking monies from another budget. Okay. So that's going to be a tough sell. But ladies and gentlemen, if we can find a path to continue these services for these programs dealing with the children, and it's difficult for me, doctor, to talk about a 19-year-old as a child, but that's just me. You know, we may have to become a little bit more flexible, a little bit more creative in how we do this.
Thank you.
I apologize for that opining, but we needed to get it said.
Thank you very much. So what I wanted to show you on this was all kids, which is our name in Alabama for CHIP, all kids enrollment and how it rebounded after the public health emergency. And I mentioned this a minute ago, but during a normal year, because of these income cutoffs, you have some churn back and forth one year to the next between Medicaid and between CHIP. So the family makes a little bit more this year. Kids are eligible for CHIP. The family makes a little less the next year. Now they're eligible for Medicaid. So you see these kids who can go back and forth when they're sort of on that income cutoff line. During the public health emergency, if you remember, anyone who was enrolled by Medicaid remained on Medicaid throughout the public health emergency. And so we had about a 3-year period where MCHIP numbers just kept going up and regular CHIP numbers kept going down. And then once the unwinding was completed, we've seen that level back out. And you can see the last 2 years on there, 24 and 25, we've gotten back to historically where we are. And typically around 90 to 100,000 kids in each one of those programs, typically. And we're back to about where we would be. So we feel like this is more representative of normal at this point. And then I'll say just finally on that, the other thing that has come back to normal, we believe, is what our state share is, the amount that we pay to draw down these federal dollars. It is approximately 20% or just under 20%. It was expected to go up sooner than it did. That was one of the reasons that we had some carry forward money during the public health emergency because the FMAP was frozen, and so we were paying lower state share than we had expected to for a couple of years during COVID. Now that the public health emergency is over, the state share has gone up to just under 20%, and that's where it's expected to stay. So we believe it'll be there for the foreseeable future. So it makes it a little bit easier to predict.
On that chart that we're looking at, what happened in 16, 17, 18, 19?
Because of the provisions in the ACA, states did not have to pay state share.
Okay, that was, but that changed evidently in 2020.
It did, that's right. It changed and was expected to jump back up to almost normal starting in 21, but then it was frozen because of the public health emergency. So we didn't have we didn't have to pay that for a while. And that's actually the last slide I had for you. I realized putting this together, it wasn't going to be real clear, and so I apologize for that. But that's kind of the best picture that we have right now.
Well, don't let our confused look scare you. That's our normal appearance. Do we have any questions from anyone on what's been presented so far?
Mr. Chairman.
Yes, sir. Senator Allen.
Yes, sir. Dr. Harris, thank you for the comments you made, and certainly the early comments that you and I've had moments ago. This is not a softball pitch to you, but I know it's probably much more difficult when you have rural hospitals that's concerning and contemplating on closing and whatever else. But of course, every hospital in this state is important, no question. I guess the question I've got is this: for instance, if there's a hospital facility available and the facility is in probably good shape, decent shape, whatever term you want to use, and the type of funding it would take to make it sustainable and make it useful, and the flip side is that the rules of the game, looking at what can be done to make something work in a rural community, county, and even going to the place where maybe establishing an ER, maybe something that will be useful. Is there any thoughts that you may have that you've been in discussions with your counterparts or in Washington on how to deal with communities that need some type of service?
Yes, Senator Allen, you're right. That's not a softball question. We talk about this all the time. I mean, this is literally what we talk to people about, and there are so many different reasons that we've gotten to the place where we are. But ultimately, the summary is there's not enough of the right kind of patients to support the hospital. In terms of what they can pay, what they can afford. What the population of the community is, and just in terms of volume, all those are really challenging situations to just easily solve. I applaud the administration for this Rural Health Transformation Grant, because that's exactly what they're trying to do, is to think of ways that we can be creative and solve these problems. But it's not easy. We have little things that government can do, and then a lot of things that the market does that the government really can't do. But in our corner, we're working on recruiting rural providers. We're trying to find ways to get people who are willing to go to the towns like where I grew up and where a lot of us grew up, and live there and practice there, and make it financially feasible for them to do that. We're trying to find ways to support other services in those communities, like EMS we mentioned, who can at least provide people access to some care, even if it's distant care. There's not a simple answer to that, unfortunately.
Yeah. So, going to looking at the rules of the game, so to speak, I know there's going to be maybe some opportunities for communities, counties, cities, towns, maybe get involved with the grant procedure, writing grants. Do you have any idea what kind of guidelines, rules of the game will be proposed for every state in this country on rural hospitals?
No, sir, I don't. I would say the most significant change that has happened in the past 2 years is the creation of this new type of hospital that we call rural emergency hospitals, and you may be familiar with those. But CMS created a brand new hospital type, if you will, called the rural emergency hospital. And these hospitals, these are, active hospitals in rural areas right now who are given just direct federal subsidies in exchange for narrowing the scope of things that they do, and for the most part, not having any inpatients at all, or certainly not any inpatients for any length of time. But keeping, laboratory services and x-ray services and emergency services and access to EMS all within the community. So we've seen a number of hospitals who've accepted that route already. The first, I believe, was in Bullock County, but there's been several others that we've had conversations with. And I think we feel like that's a good effort to keep something in the community. But, it also is not ideal either, because, once you close your inpatient beds, you lose a lot of the other medical people you would have had there, the nurses and maybe the surgeons or maybe the, pediatricians. You still have an ER, and that's good and you need that, but you've still got to get somebody somewhere, when they come. So it's a trade-off. We've had a hospital in Clark County that had a pretty good, successful OB program, and that program was doing fine, but the hospital as a whole had to make the decision in Grovefield to convert to an REH just financially because they weren't able to sustain. So we lost a really good OB program, and that wasn't the reason the hospital was having financial trouble. But without this change, of course, everything would have closed. So, I'm not being critical of that. It's just some really hard choices having to be made.
Go ahead.
Thank you.
I would like to refer back to page 10 if I could for just a second, talking about HR 1 regarding the $200 million per year. Actually, it uses the phrase up to $200 million per year for Alabama. And I know this is not a specific number. That's kind of the desired thing, but we use phrases like more likely than not in my profession. So several of these in here, the qualifying activities, are related to rural health care. What's the most likely number you think Alabama would qualify for and could get? And I know we're guessing, but an up to number, just that, I'm just kind of curious. Is that nationwide?
Yeah.
And Alabama can get a piece of that? So the number is
Yes, sir.
significantly less than 200.
Yeah. So what the statute says is that there's, $50 billion over 5 years for 50 states. And so we have to submit an application saying this is what we propose to do with that money. And then just like any grant, those applications all get scored, and either, you're in or you're not in. And, presumably every state's going to be able to get in, but we don't know that. So the statute says that $100 million will go to every state whose application is accepted. So we know that amount for sure, and then up to $100 million more, depending on the quality of the application, essentially, on how much, what likelihood there is that you're going to make a difference, that you're really going to transform rural health care. I think we would certainly, as a really rural state with a lot of healthcare needs, I would think we would have a good shot at getting most of that.
Is this your department's responsibility for those submitting those?
No, sir. So this will be run through the governor's office. The governor is coordinating this. She has reached out to us, but also most other state agencies, as well as a lot of other folks in the community. So our hospitals and provider groups and others, to get input on that. And then we're talking to them a lot about it, but we'll have to wait and see what the application is.
If I might be in clarification, this $200 million we're speaking of is the same $200 million that was spoken of yesterday by a couple of agencies too. It's not new or different money; it's the same money. So it's not a matter of $2 million and $200 million, $200 million, $200 million. It's a $200 million period up to. So I don't want everyone's eyes to get glazed over. We're talking about the same money we're talking about yesterday under the same criteria. So I just want to be clear about that.
Follow up on that, Mr. Chairman.
Well, just a minute. We've got Representative Lee, then Representative Sells, and then we've got. I better get Senator Price in on this, and then Senator if you don't mind. So,
Thank you, Mr. Chairman. And I know there's a good chance none of us in this room will be in any decision making in how that goes. But you're going to be in conversations that we may not be in.
Representative Lee, if we have anything to do with it, we will.
Well, I'm talking about how the money's determined per the hospital is what I'm talking about. Now, we may, I would love to, but I'm going to give you a scenario of the little things that we need to look at. I have a hospital. I can tell you one hospital that's getting over $7 million in property tax. They're a nonprofit. They're not paying any sales tax. They pay no property tax on a $500 million worth of property. 5 miles away is another hospital, and they're both full. 5 miles away, they're a for-profit and they're starving to death. That's the scenarios we need to keep in mind. It may not be out in the rural area, but you have 500,000 people that come to this particular area to 2 different hospitals, and one's bleeding to death, and one is plentiful. So I don't know. I know when we get down to the rubber meeting the road, we need to have, if we're a part of it, I want to know some financials and the true financials, and I want to know where they stand as far as what monies that they're getting in from local dollars. But that's a significant difference in 2 hospitals that are 5 miles apart. So I'm just telling that because we're going to hear a lot of conversation and be in a lot of talk, and that's just a scenario that I know of.
Thank you.
Thank you, Mr. Chairman. So when you talk about a rural area, I have a rural area, right? So I have 3 hospitals that's just hanging by a thread. They struggle almost every 2 weeks to make payroll. So we see the problem is from bigger cities to these small towns, and there's a bigger problem here. One is the federal wage index, and has to be addressed. Until it does, we got to try to hold these hospitals open. But what I want to say is, it don't matter where you live in Alabama, if these rural hospitals close, it don't matter if you live in a rural area or you live on the Lake Martin, you're going to be affected. Because right now, Margaret would probably tell you, you can barely get a room here now in Montgomery or anywhere. Like Paul said, full. You close these rural hospitals, or let them close. I don't care where you live in Alabama, you go to the hospital, they're going to put you in the ER, you're going to lay there for 3 days or longer. You know, so we've got to do everything we can do within our powers to keep these rural hospitals open, strategically or whatever. They're very important to the whole state.
Thank you. Hear, hear.
Thank you, Mr. Chairman, and thank you, Dr. Harris, for the presentation. We appreciate it. I think, as you can see, rural hospitals is a concern of all of us. And my question is, with the big, beautiful bill and the way it is structured, we do have hospitals that have made that move, as you said, as the emergency type situation. What do you see as far as how that's going to affect them, because their funding is different? So how is that going to affect them in the long term? Because if you have hospitals that are in the process of making that move, are they just fixing to open the door to a worse situation? And so, but I do think that it's something that as a legislative body and as our chairman and this, that, and the other in your office, et cetera, in the governor's office, that we're all concerned about our rural hospitals. And if you look at the breakdown as far as our state is concerned and the population, yes, it is going to be an issue if we don't find something how to address it. But I guess the biggest thing is my question today: what do you see as a timeline in the future as far as these hospitals that are making this move? Thank you for your time.
Yeah, thank you, Senator Price. That's a good question. I wouldn't claim to be the expert, but I don't know of anything in HR 1 that would directly change their ability to do what they're doing right now. There are a number that are in the process of doing that, and I don't believe that reimbursement that they're entitled to from CMS is any different because of that bill. I don't believe. I think again, it was, I was saying a minute ago to Senator Allen, I think the real concern is just that you're still continuing to lose services. You're just not, fortunately, losing all of them. You know, you're not turning out the lights when a hospital closes, you're keeping the lights on with a facility that just doesn't have the ability to do what it used to do for its citizens who probably still, need those services, unfortunately. So I'm not being critical of it. There's been an attempt to address federally some of the oversights or shortfalls of this program. For example, if you have a profitable OB program running and you want to continue that, why should you have to close it just because you convert to an REH? Another area that's come up a lot are geriatric psychiatric facilities. Several of these facilities that are closing have geropsych units that tend to be full and profitable and not losing money for the hospital, but you lose those beds when you convert to an REH. So there are ways that program can be improved for sure. It's got to be done in federal statute.
Right. So in as far as we're talking about beds, the way the program is structured now, I believe the beds are still intact as far as if they recover in 8 years. Is that correct?
Within how many years?
8 years.
I don't know that for sure. I'm not, but that may be right, but I'm not sure.
So my question is that, I guess for the long term, and I understand what you're saying, they may have portions of the hospital that could be profitable. But what we're having is when a lot of these hospitals, we're having I guess the best thing as far as shrinkage and the availability of people that are living in those areas. So when our population is going down, and because of the ability that they are lack of ability to be able to service some of it, that's the reason that a lot of these hospitals are hanging on, as the representative said, by a string. And so I think, I don't know, I know your feelings about this program, but to me, I think it's a salvation to a lot of areas. Because from an economic development standpoint, when you take the medical community out of a rural area, how are they then going to be able to help recruit additional industry to there? So I think anything that the state, your office, the governor's office, et cetera, can do to at least try to help this program to be successful, we need to do that because it gives them at least some hope.
Yes, sir. Absolutely. And I hope I didn't give the impression I was criticizing the program. We want those facilities to stay open as well. Our office has put together a guide for hospitals who are thinking about converting. And so we're absolutely supportive of that. So thank you for that.
Senator Coleman Madison.
Thank you, Mr. Chairman. Well, first of all, I just want to echo the sentiments of everything that's been said. I live in an urbanized area, but we are very concerned about the state of rural hospitals. If not, we have family members or what have you, but whatever happens on the rural area, it's a domino effect. We feel it all over the state. People have to travel, and with hospitals being closed, it creates an even greater burden. In Alabama, we have this thing about the buzzword now is workforce development. Let me tell you what's going to drive workforce development. It's going to be the medical public health industry. Because if we are out recruiting businesses or what have you and opening up, all of this is workforce development, you've got to have a healthy workforce. And this is an issue that we can't afford to kick down the road any longer. We are talking about, this is Alabama. It's not about the brick and mortar so much. It's about the people and the people who are going to be there to fill those jobs. So it's going to have to be something, Mr. Chairman and members, that I see that it's going to take a summit or coming together of all those entities that are stakeholders, whether it's the business, the medical, public health, education, everything. And maybe we're going to have to just kind of take a different look at how we are looking at our state right now. As I said, all the agencies that come before us, everybody's vying to try to get their little piece of the puzzle. It's a bigger puzzle. We all are part of the same puzzle. And it's not about whether this agency survives. All of these services are needed by our citizens. It's whether they all survive, and we are going to have to kind of look strategically at how we can do this. And yeah, some of the things probably will be cut. But Senator Auburn, you mentioned that this is the same 200 million that the other agencies talked about yesterday. So I want to get this clear. This 200 million says up to 200 million that was brought up. But now we say this is the same 200 million that other agencies also reference. So even if the money is coming to Alabama, this is on the public health presentation.
Absolutely.
But this is not just public health money.
That's correct.
All the agencies. So that's why I'm saying this is something that we are going to have to look into, because I looked at this, oh great, this would be a big help. But it's not just money. If it comes to Alabama, everybody's going to have their hand in the pot. So that's why I said we've got to look strategically at this. The other thing is that we're really going to have to get on the same page about enlarging the pie, and I keep using that phrase. So where can we get more revenue? What have we been dealing with? So it's the elephant in the room that we're going to have to decide, what are we going to do if we are going to get more revenue and increase workforce development. Is all got to be tied into that. Economically, how do we grow a state?
Thank you.
Yeah, just if I can, Mr. Chairman, just kind of end on a positive note. Certainly, I think we've taken a positive step in the what will begin in the 2026 tax year on the rural hospital tax credit, 100%. That'll start in 2026, and certainly that for at least the way we're staying today, 3 years. So certainly hope we see some value there going forward, and of course going back another step in the funding that we put into our hospitals out of the ARPA funds. I think that's been a positive. So we'll certainly, this is the first time I've really heard a time frame on CMS guidelines. So I'm glad to hear you say September, and maybe we'll get this all settled pretty soon. And certainly, as my chairman said, we're in open discussions with the budget office about the structure and how this will move forward.
Mr. Chairman.
Yes, sir.
I got a question. Dr. Harris. This is a softball question. Truly a softball question. If you had a bottle with a genie in it, and you had the opportunity to get 3 wishes granted regarding the healthcare system here in the state of Alabama, how would you formulate it? And I'm asking you that because you hear the problems that we have, so you being more of the expert in terms of how we can get better outcomes using the resources we have, what would be your 3 directions or paths that you would think we would look at?
I was not prepared for that question.
I know.
I just have to come here and complain once a year. You actually have to solve those problems.
And I'm just asking because we want to hear. I'd like to hear if you had that wish.
Yes, sir.
What do you think would actually make a difference?
So, well, I'll take a stab at that. I think one thing that we kind of forget about sometimes is we think a lot about provision of care for people who are sick, who need it right now, and we need to provide it for them, and of course we do. But I would just say when you get to that point, you're dealing with a bad outcome that ideally you could have prevented, right? And so we talk about preventive care some, but we as a country, not trying to criticize anybody in particular, we as a country don't spend much on preventive care compared to what we spend on taking care of people who are ill. And not that they don't need it, and I know we don't have unlimited resources, but I would say an emphasis on preventing things really is important. Now, if you want to track people's health trajectory in our state or in our country, there's a lot of factors that can predict that really don't have anything to do with medical care. So the zip code you're born in, how much money you make, how far you went in school, those are powerful predictors of how long you live. and what diseases you're at risk for. I mean, it's just true. So it sounds like a weird answer, but one way to really help healthcare is to really help education. It's to really take care of kids when they're small and make sure that they grow up and they're educated and they make good decisions and they hopefully have strong families to support them and they have all the opportunity, and people live longer when they do that. So that's clearly the first thing that comes to mind. The other thing is there's no easy answer to this, but we don't have a sustainable way for rural hospitals, for most hospitals, to survive right now because they're collecting money one patient at a time, with honestly, with Medicare and Medicaid, no criticism of any of those agencies, they're just sort of fixed amounts of money. Hospitals can't just turn their prices up when the market gets bad and charge more. They're sort of have fixed revenues, and that's the system we have. But it's clear that system's not sustainable, and there needs to be a better way to do that. That's only two ideas, but.
Well, I thank you for that because, and I appreciate you apologizing for the things that probably need to be said, but because you are such a statesman, you decided, well, I'll try and say it in a stately way. In other words, we basically are letting the people down here in the state of Alabama and throughout the nation in the sense that we are not actually encouraging preventive care to the extent that it would actually make a difference. And the next thing is the education of the young people, but it's the parents that we really have to start educating about how important it is for the health of their children, and someone said it earlier. I think Senator Price said it earlier. This is actually an economic issue for the state of Alabama in the sense of our ability to sustain and grow as a state and invite people into this state to work and build their companies and things of that nature. So I appreciate your stab at it, and I think if you will, next time, just give it a little more thought before I get it. Thank you.
Dr. Harris, before you go, I got two questions. One's for Kirk. Kirk, this $200 million that we keep talking about, regardless of what agency it filters through, regardless of how that comes through or anything of that nature, that money, before it can be spent, has to be appropriated by the legislature. Is that correct?
Yes, all money in the state treasury has to be appropriated in order to be spent. I caution you about that because there is language in the back of the budget that picks up unanticipated federal funds. Obviously, when you passed that budget last spring, you didn't anticipate a $50 billion pot that was going to be set aside for rural health care. So in theory, that open-ended language could mean that, well, we didn't anticipate it, so we can spend it for whatever we outlay in the plan. My point being, it's time to talk to the executive branch and tell them you absolutely did not anticipate that language to be used for this purpose.
So that would, if we want to make a change in that, that would require basically a supplemental bill to amend that language come January.
We'd be in a similar pathway that you took with the COVID money, where you did separate appropriation bills to spend the money.
Okay. Thank you for that clarification. Just wanted everyone to understand that where this power rests and what we may need to be looking at from a legislative point. Dr. Harris, I have one more question for you, if I may.
Yes.
If you don't mind, and I haven't given you a heads up on this, and I apologize for that. The issues dealing with Alabama sewer systems, or lack thereof, West Alabama particularly. Can you give us any concept or any idea where we are in progress or stagnation or whatever terminology would fit along that line, please?
Yes, sir. Absolutely. I know you you and I have talked about this many times. So for those of you that haven't followed that real closely, as you know, there's a real difficult issue for residents in the Black Belt in particular in terms of wastewater disposal, because the soil, if you live in a city, you just have, municipal sewer mains. But if you live in a rural area, conventional septic systems don't work very well just because of the clay content of the soil. And so you can't just put in a septic tank like I had where I grew up as a kid. You got to replace all the land in somebody's lot for fill lines to work, or, dig up their property and bring in new dirt. Or you've got to buy an engineered system with a pump and pump to a holding tank somewhere, or arrange somebody to pump that waste. You can't just use a conventional system. So by using these other engineered solutions, they're very expensive. They're very hard for average person to do. So you take people who live in rural areas, who many times may be low income people to begin with, and then, you impose this engineered solution that they just can't possibly afford. And so that's led to the situation that we've seen for many years, where people straight pipe sewage, it runs out of the house and just into a sewage lagoon, in the backyard or wherever it runs to, into a creek or wherever it runs to. So nobody thinks that's the right thing. And we've tried really hard to try to come up with ways to address that. A few years ago, there was a federal inquiry from HHS Office of Civil Rights into our state and whether that was public health's responsibility to fix that. And I'll just say, it's a long talk I can give you sometime. But essentially, they didn't charge us with doing anything wrong, but they convinced us to agree that we would get into the septic tank business effectively. So we became in charge of identifying all the people in certain areas that needed access to this kind of help. The need is unbelievably large. You can't imagine how many thousands of families can't afford these systems. So we've tried to identify the people who need the systems. We've tried to prioritize those so that people who have, certain health problems that puts them at risk from, sewage transmitted diseases and so on, get the priority on that. We sought funding from the feds, which we were fortunate to get. We were very grateful for funding from our legislature for some of those programs. And so we've worked with local nonprofits, starting primarily in Lowndes County, but also now in other counties in the Black Belt, to get septic tanks in the ground. It's been a slow process. It's been difficult to find qualified people to do the work. In many cases, you have issues with families who maybe have traditionally lived on parcel of property, but you have the so-called heir properties where people just sort of inherited over time, but nobody has a deed to the land and can't prove their ownership very easily. So it takes a lot of legal work, which I know you know about, in order just to be able to start spending public money on somebody's property, on somebody's private property. So it's been a complicated thing. We've got, at least a couple of hundred in the ground so far. There's more money available for the time being. Some of it's time limited from ARPA 2. Some of it is actually state money that the legislature appropriated to us for this work. So we're doing our best to spend all of that money. The only thing that has changed is that with the change in administration, HHS is no longer, saying it's our responsibility to do this. They've sort of said, they've sort of dropped that complaint, I guess. It doesn't change our feeling that the work needs to be done, but that's really the only change. So it's going out, a little bit of time.
Thank you for that. Now, for this body, let me give you a heads up on some of this stuff. What we have done is we have gone through and we've done a study. We have paid for the study, and we have the study that identifies where the problem exists. We know where that is. We know the people that live there. We know what types of systems will work, and there's a variety of them. And we have even identified clusters of where we can connect, and already got much of that work has already done. We know what to do, and we have the technology to accomplish it. Now, that's the good news. The bad news is we don't have local cooperation on the county level, and we don't have the monies complete to do it all. It's going to be a long-term process. I want Dr. Harris to put this in because I believe this is a major issue in developing all of Alabama. And I think we need to address it and approach it in some way and fashion. And it ain't going to be easy, but we're well on our way to solving it if we have the grit to get it done and then the money. But I want y'all to be aware that we're still working on. In fact, there's a meeting today dealing with this matter in another county, in rural county, with USDA. We have made several false starts to get this accomplished. And we need a concerted effort. We've got to deal with this in some way. But thank you, Dr. Harris.
Thank you.
Yes, ma'am.
Thank you. So when you say local cooperation, are you talking about the elected officials, local, that are not working with you or with us as we?
The difficulty is enforcement at the beginning end of it. Simply allowing folks to do what they choose rather than what's healthy. Yes, we have that problem.
I'd like to follow up on that in terms
I'll
of
be happy.
thoughts.
If you have the time, I'll take you. It'll be a long ride, but I can show you several places in which we have invested millions of dollars and they have failed to cooperate and failed to use so that it collapsed.
Thank you. With the attention and not, as I said, I'd like to have some further conversation with you. With all of the attention that we receive nationally, it amazes me that you would sit here and tell me that you're not getting the kind of cooperation, and I don't understand that.
We're pointing fingers at one another, and we just need to get together and fix it.
But I believe there's a group of people, and anyway, we'll talk.
Yes, ma'am. Any other questions? Yes, ma'am.
Well, this is a question that I alluded to yesterday. Is this because different municipalities and counties have their own guidelines and regulations that may or may not be up to par with what
I can't speak to that. I can tell you that we do have state regulation under Department of Health that requires connections, private or public, that is not being enforced local.
And the other part is, as I saw it maybe last year, is that some of them want to use certain people that their own folk or whatever. Again, whether the work was going to be done in accordance with certain standards.
Now you're talking politics getting in the way.
Well, it is what it is.
Yes, sir.
So years ago, you had to have a septic tank before the power company would hook power up. Did that go away? I guess
it did go away.
That worked really well.
I've heard that before, and I wish it. I don't know what happened to that, but
so like I said, I live in rural areas, and not everybody with a septic tank has a problem. They just don't want to put one in. Right.
Yeah, yes. I would say there's different. I mean, there's a lot of flavors to it, and in some cases you have, you have a home that has a perfectly adequate tank, but maybe the home's, a 3-bedroom home, but you have a large group of people in the same home, and it's just, you can't handle 10 people who are showering and using the toilet and cooking. The capacity's not adequate, so it's nothing wrong with the tank. Or, in some cases, you just have situations where people maybe have a tank, but they just don't have the ability to maintain it. They have to be pumped out periodically. You've got to spend money. They cost money. Once you get them, you still got to spend money on them, and people can't always afford to do that. So,
thank you, Dr. Harris, for your time. Thank you for your taking these questions and such. Any comments from any of their members? Yes, sir.
Mr. Chairman, I just have a subject I'd like to bring up that I think is affecting not only rural hospitals in Alabama, but all hospitals in Alabama. Medicare recipients utilize the hospital probably in a larger extent than any other group. And the way they are reimbursed by Medicare is based on the wage index of the state. And it forces Alabama to receive the smallest amount of payment from Medicare. Dr. Harris, you have any suggestions on how we could, I think we need to do a study on it and present it to our representatives in Washington to see if they can't give us some relief. We're the lowest paid state.
We are.
Correct.
So I'm not the expert on that topic, but it is a total flat amount of money that Medicare spends, and so they allot it to states based on the wage index. And the way to raise Alabama's wage index is to cut somebody else's, and so. And I think that's the problem. I think we sort of automatically have 98 senators and 433 representatives who are going to oppose any effort to change it here. But that's my understanding of how that dynamic is.
Okay. Thank you very much.
Yes, sir. Okay.
Any other questions? Thank you for your patience, Doctor. Thank you for here. With that, we're ending a little bit early, but I think we had a robust discussion. We'll go into recess till 1 p.m. today. Thank you. We're ending a little bit early, but I think we had a robust discussion. We'll go into recess till 1 p.m. today. Thank you.